but I have the distinct honor and privilege to introduce my good friend, colleague, an extraordinarily awesome guy who I have had the pleasure of working with for about a decade now in his various roles. And now I'm honored to introduce him in his role as a Chief Technology Officer, Bruce Greenstein of the United States Department of Health and Human Services. As a CTO at HHS, Bruce provides leadership and direction to ensure that HHS effectively uses data, technology, and innovation to improve lives of American people and the performance of various divisions that operate within the Department of Health and Human Services at the federal level. But our journey began in his role when he was the Secretary of the Louisiana Department of Health, DHH at the time, Department of Health and Hospitals, where he and I collaborated on the first ever Cajun Code Fest in response to a call from his predecessor, a guy named Todd Park, who was the Chief Technology Officer of the United States Health and Human Services, when he came into Louisiana on November 29th of 2011, and had a conversation in Baton Rouge with Bruce and his team at DHH and folks from UL, talking about what Todd was doing across the country in his role as a CTO of HHS at the time, doing code fests and hackathons. And he challenged us to see if we could do something of that nature. And when he came back 5 months later for our inaugural Cajun Code Fest, Todd Park said that that was the biggest hackathon, codeathon that he had ever, and the best that he had ever been part of. And today, we've topped it by an extraordinary measure. And on his way out of Lafayette, Louisiana, Todd Park tweeted that Silicon Bayou, aka Lafayette, Louisiana, was the best kept secret reservoir of innovation mojo in the United States. I remember that tweet like he said it yesterday because my president teases that I have that tweet tattooed on my you-know-what. But I'm very proud because that tells us a little bit about what a Chief Technology Officer of the United States Health and Human Services thought about Lafayette, Louisiana, or the state of Louisiana for that matter. And I have to tell you, in his new role, succeeding Todd, Bruce has raised the bar. In our collaborations with him over the years, Bruce has continued to be a phenomenal inspiration that has allowed us as partners and colleagues of his to work with him in some extraordinary things that, so I told him last night that everything that I'm proud of that I have done in my life, other than marrying and being the father of twins, I attribute to Bruce and our collaboration. No pressure, take it from here.
All right, good morning, everyone. Thank you very much for the generous introduction, and I'm going to try not to think about that tattoo on you. All right, so here's the story. We put on this codeathon, and there's just some irony in it that I was the Secretary of Health, and Todd Park was the CTO, and then here I am getting to be the CTO and getting a chance to work with Rebecca Gee, with whom I worked when I was secretary here, and it's just a small family that always stays together. And what's really nice about it, this is one of those areas that really just purely cuts across kind of politics and noise and gets right to the things that add real importance to what the state is doing and what the economy is doing and doing value creation in the private sector. It's really, really nice. We've got a very cool panel that we're going to go through today. Public sector, private sector, previous public sector, and now private sector. You'll get a lot of perspectives on this, but I want to just kind of frame things up from where I see it. Dr. Cassidy this morning gave a joke. It seemed like there was a lot of doctors this morning with a lot of jokes, and I'm just an economist, and we're not really known for our humor, but it reminds me, President Reagan used to say that if economists had designed Trivial Pursuit, there would be 100 questions and 3,000 answers. See, it's not even that funny. I thought it was really funny when I memorized it. A couple other economists were in a nudist colony, and they're sitting out in the sun, and one turns to the other, "Have you read Marx?" And the other one said, it's just the wicker chairs. I see, think about that's a good one. I like that. So let me just say a couple things. That was, I think, pretty funny no matter what, even without the economist part. Here's what I want to talk about to frame this up. I'm going to do a presentation at the end, sort of clean up about what we're doing in Washington, D.C. Through the administration. And Senator Cassidy talked a lot about some monies that have been allocated recently, and I'm going to talk about where it's going and how we're doing it. People here that are running the State Department of Health are putting it into work. But there's part of what I want to get out of today that I take back to DC, which I think really envelops where we are in the opioid crisis. If you think about why we're here, who's here for the Codathon specifically? In other words, who's got their hoodies on? Good. Thank you guys for being here. It's always hard to talk to my people with a tie on. It just doesn't seem authentic, but I have to do this in the morning, and then tonight I'll come back in t-shirts. This is really an expression of government humility. This is where we say we don't have the answers. This is the most important public policy and public health issue that we're facing in our lifetime, and we don't know exactly what to do. So we turn to our best and our brightest all across the country to come volunteer, to work with us, to give us ideas, to provide answers and solutions. And there's no credit claiming, it's all crowdsourcing. And we take everything that we can get, and I'll talk about some results that we had from our Codathon in Washington, D.C. in my slide presentation. But we're really trying to figure out what to do. And so if you work in SAMHSA, which is our mental health and substance abuse agency, you have opioids in the crosshairs. It's very clear. If you're at CMS and you do healthcare, you know what to do, CDC, etc. If you're the data geeks at the office of the CTO and you know that data can save lives, you have to make that expression somehow. And we can do it with making our data more available, making it more illustrative, providing more insights from it. And we're doing that now, but we really need help. Our data, for the most part, comes from states first. We don't want to wait. I'll give you this quick story. When I got to DC in the beginning of last year, we were talking about the opioid crisis, and we were saying how bad it was, and we'd show our charts and graphs. And the data was from CDC and reported from 2015. And it's hardly credible to talk about how bad it's getting when you're looking at data that's 2.5 years old. Well, we were actually sitting on the data, but it hadn't been properly cleaned and verified and approved back to the states. But we started to make some adjustments, created new agreements with states, and now we're posting data on opioid deaths about 6 to 7 month lag time. And some states are doing it on a quarterly basis or even monthly basis. And that's helping those in the treatment community and law enforcement community allocate resources in a better way. It's one example of just moving data from pretty stale and latent to a lot more fresh and potent. And I think that what we'll find today are some ways to look at data better, to have a more cleaner and precise version of it. And then when the coders get their hands on the data, which may be incredibly interesting and more connected at the state level than it is at the federal level, that will open up answers that we don't have access to today. So again, this is a very somber topic, a very serious topic, but at the same time, it's a topic that all of us can get together to try to help make progress on. So with that, I'm going to begin the process here. I just met a new friend this morning, Dr. Clark. He started his job while I was still here in Louisiana. He was an appointed member of the Louisiana Commission on Preventing Opioid Abuse and is the coroner for East Baton Rouge Parish, which is where I lived at the time. Dr. Clark's mission has been to engage his office fully in 3 jurisdictions: death investigation, mental health investigations, and sexual assault investigations. He's currently serving as the president for both the Louisiana State Coroners Association and the Louisiana State Medical Society. So thank you very much for being here.
Thank you so much. Can everybody hear me okay? All right. So like you said, I'm Dr. Beau Clark. I'm the East Baton Rouge Parish Coroner, and I'm happy to be with you this morning, and actually I'm talking first, which is very unusual for a coroner because we usually talk last. Oh, that's a coroner joke. Okay. All right. Tough crowd. I got it. Okay, so a little bit about my background. For about 10 years, between 2003, 2013, 14, I was assigned and participated as a sheriff's deputy with the East Baton Rouge Parish Sheriff's Office and their SWAT team. I'm what they call the door kicker. Has anybody heard that term before? The door kicker? So I had a responsibility to, when street-level narcotics agents would make a case, they would go to a judge, we'd get a warrant, and then they'd send the door kickers in. And we go into a house, we kick the door, we get the bad guys and the drugs. And that's what we did. We did it for 10 years. And I could tell you during that time frame, we took a lot of cocaine out of people's houses, and we took a lot of marijuana. But one thing I never saw was heroin. And the reason I tell you that story is because we're about to dive into what I call the story of heroin and how it happened, okay? And you'll see how that synergizes with what's going on in our opioid epidemic. So let's talk a little bit about heroin. We'll start. That's me last time I was seen not wearing a bow tie. Anyway, heroin is an opioid painkiller. There's the fancy name for it. It's a derivative of morphine. It's a recreational drug, meaning it has no medicinal purposes whatsoever, and people use it because they get high. It provides a euphoric effect. Its side effects, though, include CNS and respiratory depression. And if you depress your respiratory system enough and you stop breathing, what happens? You die. And that's what makes it dangerous. You can see in this picture to your left, it comes in various forms. It can be a brown powder. It can be a white powder. Sometimes it's a black-looking powder. They call that black tar heroin. But nonetheless, when we think about this in our mind, we think about a powdered substance, a needle, and a spoon. If you close your eyes and say, what is heroin, that's what you see. Postmortemly, however, we never find heroin in anybody's system. So when I draw your blood or urine after you've died and we check it through a laboratory, we find a drug called 6-monoacetylmorphine, or 6-MAM for short, and it's because heroin, once it enters your system, rapidly metabolizes into this 6-MAM. And that's what we're looking for. So when we find 6-MAM in your urine or blood, it tells me that your death is potentially related to the use of heroin. Okay? Real quickly, we got to understand two terms, potency and tolerance. Potency is the illicit response for a drug as it's prescribed. So, for example, if you take a 200 milligram Motrin, we know that there's going to be an effect related to the potency of that drug. Okay? And that is done through an FDA process that's done through the manufacturing of that pharmaceutical. How many times do you think heroin dealers go to the FDA and get their drugs tested? Whopping zero. Okay? All right? So, if you're a heroin addict and you go to buy heroin on the street, do you know its potency? Absolutely not. It's not been tested. So it might be 0% potent, meaning it's not heroin at all. It might be low potent, like 10 or 12%. It might be very potent, like 50 and greater. All right? And as a user, you're going to use a set volume of that drug. And when you use a set volume of that drug and you don't know the potency, you get yourself into trouble. And that trouble is overdose and death. The second piece is tolerance, and we understand that when we talk about opioid prescriptions, your body can become tolerant to it. Everybody has heard the story of the person who said, yeah, I took a 5 milligram Lortab or Norco or whatever, and after a while that didn't work, so I had to take 2 of them. And after that didn't work, then I had to move from hydrocodone to oxycodone, and then oxycodone didn't work, and I had to get on fentanyl or some other really, really powerful opioid. That's because of tolerance. Your body creates a tolerance to the drug. So why do I tell you about these two terms is because they develop into 2 situations we commonly see with overdose, okay? One is instant death in the naive user, someone who's never, ever, ever used heroin before, okay? They've now made the transition from using prescription opiates. They're going to use illicit drugs like heroin or fentanyl, and they use it for the first time, and they don't know its potency, right? And they overdose as a result of it. That's the naive user. Very common. The second situation is when we see a person who has is a chronic user. They go into rehab. Their tolerance then lowers to a baseline as if they've had it before. They use the drug, and it's like being a naive user. They use it for the first time, excuse me, and they have instant death from respiratory depression. So those are the 2 situations. So here's the problem with heroin. So like I said, back in my day in law enforcement, never saw heroin. Become the coroner in 2012, I have 5 deaths in our parish that year from heroin. So I start scratching my head. Well, all of a sudden, do we have heroin in our community? It didn't exist before. We never found it on any of these drug raids, but all of a sudden, I got people dying from it. The following year, that number rose from 5 to 35, a 7-fold increase in heroin deaths. That's a problem. We knew we were in the midst of something. So these are the numbers for heroin in East Baton Rouge Parish. You can see 5, 35, 27, 41, 34, and an all-time high of 45 last year, okay? Now, those numbers may look low, they may look interesting to you, they kind of go up and down, but what I want to point out to you is when I add other drugs, mostly opioids, over the top, you can see how those numbers begin to climb. So we get to an all-time high of 111 overdoses related to opioids, whether they be heroin or non-heroin overdoses last year. Now, if you break down what's in the other drug categories in the blue, and you see this dip that occurred to 34 in 2016, that's where fentanyl showed up, okay? Fentanyl's part of that blue line that's above that. So all of a sudden, we went from illicit heroin on the street to now more illicit fentanyl on the street. But it creates the same problem because they're both opioid drugs. So you have to look at this and say, you never found heroin when you kicked the door, but now all of a sudden we're in the midst of an opioid/heroin epidemic. How did this happen? What is the why? And so in our analysis of the why, these are the things we found. In the early part of 2000, the Louisiana legislature was doing some prison reform, much like they're doing now, and they said we have too many people in jail that are serving life terms because they're non-violent drug offenders, meaning they sell Schedule I narcotics, okay? The law used to say if you sold a Schedule I narcotic, and in that schedule are things that are non-medicinal, like LSD, heroin's in that, marijuana's in that schedule. They say, and I know there's some debate, we're not here to debate medical marijuana, but the point is Schedule I narcotics, you got life in prison for distribution. And does anybody know what life in prison means in Louisiana? Life in prison. That's it. That's what it means. It means exactly what it says. You go to prison for life, okay? What we decided to do was, because they were worried we had too many non-violent drug offenders in jail, that we needed to reduce mandatory sentencing for those Schedule I narcotics. Well, what they forgot about was heroin was inserted in there. And I don't really think heroin is a non-violent drug offense, because I think at the end of a heroin sale is the potential for death, right? Okay, so it should be kind of carved out. But nonetheless, we went from life in prison all the way to the very bottom, 5 years, okay? And 5 years means 18 months, good behavior, parole, etc., okay? So we went from the top to the bottom. What did that do? That told all the drug dealers in the world that, hey, come to Louisiana and sell heroin. It's a great place. We put a big sign up and said, come to Louisiana. If you get in trouble, it's only going to be 5 years, no big deal. And then they showed up, okay? They showed up to sell their heroin. At the same time, in 2010, the state participated and invented, through the Louisiana Board of Pharmacy, a prescription monitoring program. We knew there was a lot of doctor shopping going on. You've heard these terms before, where people were out in the community looking at different doctors and grabbing these prescriptions, right? Sometimes they would use them, sometimes they would sell them. And the pill mills and all this stuff was happening. Well, the Board of Pharmacy was going to break down on that with the advent of the prescription monitoring program. And what did that do? It worked. Okay? All of a sudden, that plethora of opioid prescriptions that was floating around in the community that people were abusing dried up. And who was standing on the sideline in that scenario? The heroin dealer. They said, oh, well, look, you can't get your prescriptions anymore, but I got something right here for you. Okay? And I moved into your state because you've got weaker laws than other states did. Okay? You see how that works? All right. What else? We also invented this thing called the pain scale. You heard Dr. Gee speak about this morning, right? There are 4 vital signs, in my opinion, that are scientifically calculated. That is, what? Your temperature, your pulse, your respiratory rate, and your blood pressure. Those are all scientifically calculated. And then we decided, well, we need a 5th vital sign, right? And what's the 5th one? Your pain scale. And what is that? Completely subjective, right? I'll look at you and say, what's your pain? You say, it's a number, and then I react as a clinician. Like, okay, number 5, that gets you a dose of morphine or something, right? So completely made up. But here's the catch. Do you know who invented the 5th vital sign, the pain scale? Big Pharma, right? You know what Big Pharma sells? OxyContin. Wow, that's pretty interesting. So they convinced the federal government that we should have a 5th vital sign and that we should treat people's pain as related to the 5th vital sign. And oh, by the way, we have a drug that you can treat it with. It's called OxyContin. Okay? Right? Pretty scary stuff. Also involved in that was a plethora of what we call patient satisfaction scores. So how many clinicians do we have in the audience? Right? Everybody heard of patient satisfaction scores? Right? Okay. So For everybody else, a patient satisfaction score is much like when you go to a hotel and they say, how was your stay? And you list all these things, right? The pillow was soft and the bed was comfortable, and so they do the same thing in healthcare, right? They say, well, how was your visit to the ER, right? There was no blood on the wall. That's like good stuff, right? But they also said, well, how did they manage your pain? Did they address your pain, okay? So now all of a sudden we've turned these questionnaires and these patient satisfaction scores in on, did you get high? That's what I read when I see that, right? Okay? And if you're an addict, that's what they're really asking you. And as a clinician, what am I forced to do? I want you to have good patient satisfaction scores, right? So I'm forced to do something about their satisfaction, which is not scientifically based, it's subjective. And that's a problem, okay? So we put all that together, and there's the patient satisfaction surveys, and we created the perfect storm in Louisiana, okay? Right? The perfect storm was what? We invited the heroin dealers. We cut down on the prescription drugs that we were handing out because of the prescription monitoring program. And we created things that were not really based in science on the treatment of pain. And we created the problem. All right? And that's what we collectively created the problem. Okay? So, things I want to note before we go further into the discussion is understand this. Heroin dealers are rarely heroin users. That's important. Other drugs are not the same. Sometimes people that sell marijuana also use marijuana, and the same is for cocaine, okay? But heroin dealers typically don't use heroin. It's very rare. Why is that? I love donuts. I cannot own a donut shop, okay? Because you would come to my donut shop, and I'd be like, I don't have any donuts. I ate them all, right? Makes sense? Okay? So that's what we're dealing with here. You have to understand that in this scenario, the heroin dealer is a business person. They're there to make money. They want to sell this drug. They want you to use it. And sometimes you come back and sometimes you don't. And they're not so much worried about that because they have an endless supply of people coming through the front door. So if somebody dies as a result of their overdose, it's not going to impact their business, okay? Because we have so many people. And you also have to remember that the person who is addicted, the patient in this scenario, is not only physically addicted to the medication, they're psychologically addicted to the medication. So if you're going to treat that patient, you got to treat them twofold. So let's talk about the bad guy, all right? These are the guys I used to go after. They're in the business to make money. They want to sell a product that's in high demand, which it is. They have a customer base that'll do anything to get the product. Those are the users and the addicts. They're looking for an environment with a high return on investment and minimal laws that make business risk averse. Does that sound like something you would read in an economics class? Right? Right? It does. And we're talking about drug dealers here. Okay? And obviously they have questionable ethics. The bad guys in Louisiana, guess what they used to sell? Cocaine. Guess what they sell now? Heroin and fentanyl and all these other stuff. You know why? 2 reasons. They make more money doing it. Okay? And the second reason is the cartel, where they get the stuff from, makes them do it. All right? Does everybody remember the 1980s? I know that there were some younger guys I saw girls standing up earlier, but 1980s hit show Miami Vice, right? Crockett and Tubbs, Miami there solving the world's problems with the Colombian cartel, and cocaine was king, as they say, okay? It's those same people that have changed their business model from the sale of cocaine and importing that into our country that are now bringing in these illicit opiates, okay? And they've also gotten very creative in their other forms of distribution. So like we said earlier, when you think in your mind, heroin, needle, spoon, etc., right? And you're thinking, my God, how could somebody actually make that jump from taking a pill to injecting themselves, right? Has any clinician had to give themselves a shot here? Or anybody had to do that? That's pretty tough, right? How do you convince yourself? Do you go on 2, tell yourself you're going to go on 3, but then go on 2, but it's really yourself, right? So that's a tough thing to do. So what they've done creatively, and we've discovered this, is they'll take heroin and press it into a pill. Take a pill press. Make it look and you know what they make it look like? They make it look like a hydrocodone, right? Because what's more expensive, heroin or hydrocodone? Hydrocodone is now, okay? Right? And if I convince you this is hydrocodone, then you'll pay more money for it maybe, right? Pretty unethical. But nonetheless, you don't necessarily have to make the jump from injection to injection. You can also make it to ingestion, taking a pill. You can smoke it, you can snort it. It comes in different forms. And so they've been very creative in that distribution model. So let's talk real quickly about the good guy. The good guy is the patient. These are all the people that have become addicted. These are the people that are users. They're our patients, and they're the ones that we got to fix. They need our help. Remember that they are in need of both psychological and physical treatment for their addiction. So let's talk about general solutions, because I hate to come in here and tell you all the bad news, right? The doom and gloom. But how can we fix that? Because that's really what we're really talking about today, right? Is how do we fix this problem, all right? So I'm going to give you the big view of how to fix the problem, and then we'll kind of break it down into smaller pieces. 3 things you got to do. Wow, and you're thinking, Dr. Clark, you said 3 things and we're done? That's pretty good. This short list, right? I mean, my wife gives me a longer grocery list than 3 things, right? So 3 things we got to do. Number 1, illicit drugs, right? That's the DEA. That's the cartel. We got to get those out of the country. Yeah, absolutely. That cannot stop, okay? Because as long as the illicit drugs are there, people are going to use them, all right? And they're deadly. Number 2, all right? We have to be better prescribers. As a prescriber, as a clinician, I've got to watch what I prescribe. I've got to curtail my prescription habits because I don't want to create any new addicts. We got enough already. We don't need to create any more. And do we know who the addicts are? Can I look around the room and go, oh, that person, and that? I can't do that, right? So every time I write a narcotics prescription, I run the risk of that person that I wrote it for becoming addicted to it. And if I give them a bucket to go home with of hydrocodone, guess what? I made it pretty bad. I made a bad decision, a bad clinical decision. So the third part of it is we've got a large group of people that are in the middle. Those are our patients. Those are the people that are addicted, and they need treatment for their addiction. Okay? So those 3 things, we figure it out. We solve that. We solve this problem. So let's look specifically how we do that. It is complicated. I'm not going to say it's easy. There's a lot of pieces and parts to it. But what can we do? Simple things. How about we stop using the pain scale? How about this? I'm a clinician. I walk in and say, hey, I'm Dr. Clark. I'm here to see you today. What brings you in? I've got ankle pain. Okay, good. Well, you've got pain. What's my job? Treat your pain. We don't need to talk about what number, or if it's a smiley face or a frowny face or any of that stuff, right? We have a relationship between the patient and the doctor in the treatment of their pain, right? What are our options for treating that pain, right? A couple, right? Could be anti-inflammatories. Could be elevation. Could be a little ice on your ankle, right? Sometimes it might be a pain if it's broken. Maybe you do need an opioid, but maybe you need a small prescription of opioids, like just a day or 2. Okay, all right. There's another thing out there, right, which is called just suck it up, buttercup, right? You can use that as well, right? Has everybody experienced pain in the room? Some form, right? You get out of bed and something hurts, right? And then by the time you walk 2 steps, you're good. All right? So you don't always need something for your pain. All right? So you have to have that conversation, though, obviously. Education and prevention are good things. Managing the bad guy, okay? Managing the bad guy. Remember, heroin users and heroin dealers, 2 different people, okay? So manage the bad guy and manage the cartel, all right? Recently in Louisiana, this was last year, Act 82 and Act 76 by the representative and the senator there, was a effort to curtail prescribing in the state of Louisiana. Essentially, what the 2 bills did that are now laws said the following: as a prescriber, I am not allowed to write more than 7 days of an opioid prescription for the treatment of acute pain. Okay, I think 7 days was a little long, but that's what we negotiated. Probably 3 would have been the appropriate number. But anyway, that was the first part of it. The other part of it says if I go more than 7 days, I got to explain to you as a clinician why. And I also have to document why, and I also have to run your name through the prescription monitoring program if I do so, okay? The last piece was the continuing medical education piece you heard about this morning. We're all required within the next year and a half, essentially at this point through 2019. I know Dr. Collada is here. You may talk about this later. 2019 mandatory CME for prescribers, okay? And I use the word prescribers because that's very important. It's not just about doctors, because guess who else writes prescriptions? Dentists do, right? Other levels of the healthcare providing system, such as nurse practitioners, et cetera, that have prescriptive authority. So it's all prescribers have to be responsible for this. And lastly, how do you treat the addict? You treat the addict twofold. You got to treat them psychologically through medically assisted through cognitive behavioral therapy, working on their mind, and of course, remember their physical addiction. You have to treat with medically assisted treatment. And that's tough. You know why that's tough? It's tough because that's what costs the most money, right, to treat these people. Because we don't know how long somebody has to be in therapy. It's not like you can show up one day and I'm getting buzzed out here. You can show up one day and take a pill, and then your addiction's over. Sometimes for these people, it's a lifetime. It's a lifetime problem. It has to be solved that way. So, all right, there's some references. I have questions and answers after that, but I know we have a panel, so I'll leave you with that. Thank you so much for having me today.
All right, thank you very much. Seeing the perspective from somebody who is analyzing the results of overdoses is illuminating, and we just got to some conversations before the session, and I was reviewing prescription data, overall U.S. prescription data, with a company that compiles all the prescriptions in the U.S. called IMS Quintiles. And what I saw was something that seems to be a success of U.S. public policy. From 2013 to 2016, there was right at a 50% reduction in total number of prescriptions written for opioids. So in 3 years, the number was cut in half. At the same time, also, morphine equivalents came down 50% too, so it wasn't like squeezing the balloon in one place and it turning out in the other. During that same time, the number of deaths have been climbing dramatically. We saw the data here, but we see it all across the country as well. And so part of what we're trying to get a handle on is what we're doing is pushing one problem from prescription opioids to illicit drugs, and then within illicit drugs are those going from heroin to fentanyl. And the data is starting to show us more and more what's happening. And so the 3 steps that Dr. Clark talked about today was really important because it acknowledges the problem that was caused by prescriptions, and dealing with that today is absolutely mandatory. At the same time, thinking about stopping the problem tomorrow with another set of solutions. And so for all the coders that are going to be thinking about solutions by looking at the data, take in these the way that the data is being analyzed today, the way that public policy is being viewed through these lenses, and use it as a way to look at our state's data to come up with fresh solutions to go forward. Okay, we have the next speaker, and this is somebody who I met earlier this year and is one of my new friends. Mr. William LaBar is the Vice President at CGI Federal. Will leads the Lafayette Delivery Center here, which is just across the street for CGI. They've done amazing things by adding more than 400 jobs in Lafayette over the last 3 years and growing a technology and innovation ecosystem here in Acadiana. And I have to say, I got a chance to tour the facility when I was here. And these are not simply call center jobs that are commoditized. I saw a group of really curious and very smart people, engineers with, you can see their desks, multiple monitors, hundreds of rows of data, but also 3D printing models and other parts, machines that these engineers are putting together to solve real life problems. One had to do with streetlight issues across the state. Having smart people like that, a place where people that graduate from a great university that we have here with STEM degrees, and putting them to work here in our community to solve problems in our community and our state is something really great, and I'm happy to have CGI here, and thank you for being a sponsor today. So you're up next.
All right, hi everyone, my name is Willa Barr. I'm with CGI. Thank you for the kind introduction, and if you had told me this morning when I woke up that I would have, that following a coroner would be a tough job, that was an amazing talk. And I was worried about following Bruce, but now I'm intimidated. As Bruce was describing, we have a partnership here with UL and the state of Louisiana and the Lafayette Economic Development Authority to open up a delivery center here. We did that in 2014. We have over 150 members working in the healthcare industry right across the street, supporting customers like Cigna, for example, as well as supporting CMS, and we have a team up in DC who supports the Office of the National Coordinator with Bruce and his team. I'll tell you just a little bit about that later. But I have a confession to make a little bit. I'm not from the healthcare space, so I have major imposter syndrome going on right now. And so when I was thinking about how I would have any sort of relevancy to this particular audience, and specifically I figured I would talk to the folks who are engaged in the hackathon, I don't deal with 42 CFR as Dr. Calicut was talking about earlier, or not doctor yet, sorry. As David was talking about earlier, I deal with 40 CFR, which is the Code of Regulations for Environmental Enforcement. And so when I was trying to figure out how to make my background relevant to your challenge, I wanted to tell this story, which occurred in April 17th of 2013 in the town of West Texas. And what happened was a fertilizer plant there exploded. And it caused a crater there that was 93 feet deep. It caused a minor earthquake in that area. This is right around Waco, and spread debris in a 2-mile radius. And within a quarter of a mile radius of this fertilizer plant was a nursing home and a middle school, and within a half a mile, a high school. Right? And what the story of this plant is interesting, and I'll eventually, trust me, this comes back around to the opioids a little bit, is that it was last inspected by OSHA in 1985, and they were fined for violations related to how they were storing anhydrous ammonia, right? And then TCEQ cited them for violations in 2006 at a state level for not having a permit for some of their storage tanks. In 2006 as well, EPA found that they weren't filing a risk management plan. A risk management plan, if you're not familiar with this, if you have a certain amount of toxic substances at your facility and an explosion happens, EPA calculates an off-site consequence analysis zone, or the area around your facility that could be destroyed as a result of an explosion. And sure enough, that nursing home and that school were inside the OCA, right? And so they weren't filing the RMPs. 2012, DOT fined them for violations regarding to how they were storing anhydrous ammonia as well. And then open records from, that's the city of West, the Texas police, the local authorities, they had a series of thefts occurring at this plant, and the suspicion is that those thefts were related to people trying to make methamphetamine from some of the substances that were stored there. And then, this was news to me when I researched this, but Department of Homeland Security requires to be notified if you have more than 1 ton of ammonium nitrate at your facility. And the West Fertilizer plant had 540,000 pounds of it. And they've never informed DHS. Right? No one knew any of this, and what's interesting to me about this, and this goes back to the hackathon, is in the environmental space, we have these silos of information, and we don't have this interoperability and the ability to share data across these different domains. And if that had happened, we would have potentially seen that this is a high-risk facility, right? And I think this story crosses over into your all's domain, where if we can establish that interoperability across the healthcare provider ecosystem, as well as other subjects, we might be able to find where there are high-risk patients or high-risk communities and get into prevention as well as appropriate methods of treatment. And so to me, this was the best parallel I could draw between my 40 CFR world and your 42. And we do some work with Bruce's team. I mentioned it earlier, and we have an example of something like this with some software called Connect, which is based on National Health Information Standards and allows health information exchanges to occur on top of EHR systems. And so we did a project with the PMP interconnector, the PMP gateway, which allows you to access prescription data from all the states that you see here in the green. It's a little bit different than David's map. I wasn't, maybe my source wasn't as good, I'm not sure, or maybe some of these are projected. But these are all the states that are participating in this exchange of prescription data. And so the project we worked on was working with a company called Apris. They have a PMP gateway to get this data out through that exchange and bring it into sort of your ecosystem inside a healthcare provider system, and be able to more easily see a patient's history related to prescription drugs. And this was done for Veterans Affairs as a prototype to sort of take a look at soldiers before they were going out to the field of battle to understand if there was any particular risk there associated with it. Ochsner implemented this on top of Epic. David was talking about how they implemented a very similar solution on top of Cerner. And this is where you see, and to go back to my earlier analogy, maybe just one of those 2 silos that were existing starting to break down because of this interoperability and standards. But the problem is as I was researching this a little bit, and my data's dated, sorry, Bruce, this is from the New York Times. I just thought it just told a really stark story, right? A picture tells 1,000 words. And this is overdoses deaths in the U.S. Starting in 1999. And this strikes every community across all different kinds of demographics. And in order to get to this problem, maybe as we're thinking through the hackathon and you're coding through this, maybe look outside of just some of the direct medical data that's out there and start to look at some other causes and other data that's available, openly accessible to us. So in New Hampshire, maybe access to treatment programs, or in Appalachia, we have a really high rate of this because we have a lot of blue-collar jobs there with high occurrences of injuries. And so understanding the workforce demographics associated with some of the data that you'll be seeing through the portal that's been stood up. And maybe looking at some of the environmental and social stresses that are around individuals in these communities, and maybe bringing a creative solution to the table through the course of this challenge related to that. Specifically things like economic disparities, housing instability, education quality, right? And also things like access to quality health. These are all different domains that's similar to that West Texas explosion that happened. If we can merge this data across the board, maybe we find creative solutions to help attack this challenge. I put this specific line here for Jian, so you have to listen to me for 1 second. We were at dinner last night. Jian's with Lafayette General Foundation, and I was like, how do I speak to a group of people about environmental conditions and opioids? And he's like, well, only I could come up with is if maybe you start taking a look at the waste treatment that's coming out, because maybe there's a high concentration in people's urine. And sure enough, they're actually looking at doing that in Cary, North Carolina, right? So this is a part of the Bloomberg's Mayor Challenge, where they're trying to use geolocation and taking a look at the concentration of substances coming through the sewage treatment plant in order to figure out where they might have communities at risk. And that was just too perfect to pass up, Jian. So it's like another just great example. And you can see here what the mayor's talking about. And these are game-changing types of ideas when you can figure out ways to take data across these different domains and pull them together, right? And so I'll leave you with this quote. We're not students of some subject matter, but students of problems. And problems may cut right across the borders of any subject matter or discipline. And this is a philosopher, I think he's Austrian, and I didn't know about him until last night at 2 a.m. when I pulled that slide together. His name's Karl Popper. But if I can, maybe just sort of add to that, I think the solutions need to cut across all these disciplines, and I really look forward to seeing what the coders come up with in the hackathon. And if I didn't say earlier, we are a proud sponsor of this event, and thank you, Ramesh, for your partnership and the opportunity to speak to you all today. And good luck on the challenge. Thank you.
All right, Will, thank you very much. Karl Popper actually wrote on the philosophy of science that was important to each domain, including economists. Speaking of economists, why was astrology invented? To make the discipline of economics seem like a more accurate science. They just get better and better. A couple things that I want to say, and we're going to introduce some researchers here in a minute, but we're going to be lucky enough to have Senator Freddie Mills, T-Fred's here later today, and he's going to be chairing the panel in the afternoon. So he also is an old friend during my time as secretary here, and he helped pass so many important pieces of healthcare legislation and keep our healthcare system moving forward. So I'm delighted that he's going to be here. So for the next, we have three speakers, and what I'd like you all to do is introduce yourselves before you launch into your presentation.
I'm Chen from UL Lafayette. I'm doing informatics research.
I'm Yang. I'm a assistant professor in psychology.
I'm Jada Hector, and I'm an LPC and Adjunct instructor.
So we're started. So I'm Chen. I'm team with Jian and Jada Hector. Have a joint presentation entitled Opioid Epidemics, Awareness, Treatment, and Response. I will introduce some informatics work to promote awareness of opioid problem we did, and Yang gonna discuss some addiction treatment research, and Jada will summarize the opioid situation and inspire us to think about what we can do. So a little bit background. I know so many experts already talk about opioids, often referring to both synthetic drugs as well as natural products. Those prescriptive opioids can be used to treat moderate to severe pain. It also can be used to treating coughing and diarrhea. And we know that opioids can make people feel very relaxed and high. And there are so many data out there related to opioids, such as death toll and hospitalization, patient treatment, and prescribing patterns, and even behavior surveys. The challenges are how we leverage those data, how to ask the right questions, and then find answers to those questions. And there are so many type of analysis you can do with different level of usage and with different level of difficulties. For example, descriptive analytics can answer questions like what happened, and exploratory analytics require more interaction, can answer questions like why did it happen this way, and predictive analytics looking forward try to tell us what will happen next, and more advanced prescriptive analytics will answer like what are the best course of actions for the given conditions. I will show some example using Medicare opioids prescribing data. The first question we want to ask is where people get more opioid prescriptions. In terms of Medicare cost per capita, the top city in Louisiana is not New Orleans nor Baton Rouge. It's the city of Cummington in St. Tammany Parish in 2013 on the left. In 2015 on the right, city of Cummington still top of the list, but you see the cost actually triple within 2 years per capita. The elder care facility quick expansion in that area probably can explain why. Next question we want to ask, what the top opioids be described in Louisiana? In 2013, the top three are hydrocodone, trauma, and oxycodone. The order in 2015 still the same, but you see the third one, oxycodone, tripled within 2 years in both number of prescription and the cost. All those three are painkiller with high risk of addictions. The next question you may ask is, who are the frequent opioid prescribers? According to our analysis, in 2013, the top four are internal medicine, family physicians, and physical medicine and the rehabilitations, and interventional pain management in 2013. In 2015, the top four still the same, but the physical medicine and rehabilitation and the interventional pain management take the top two seats in terms of cost, but still stay as third and fourth in terms of number of prescriptions. It tells us that those physicians tend to prescribe more expensive opioids. And there's some facts I'm not sure on the slide, but you want to know that, say, optometry and medical students are the top 11 and the 12, respectively, in the frequent opioid prescriber list, according to our analysis. And the next question you may ask, hey, where are those opioid prescribers are? In 2013, the top three are interventional pain, pain management in Baton Rouge, internal medicine in New Orleans, internal medicine in Alexandria. In 2015, we have a new champion. It's interventional pain management in Baton Rouge, and followed by physical medication and rehabilitation in Baton Rouge, and internal medicine in New Orleans. Now I want to look at a predictive analytics example. We want to predict how likely a physician will prescribe opioid based on their specialty and a non-opioid prescribing training. The machine learning model we train can predict an opioid prescriber with 82% of accuracy. But most interestingly, when we plot the relative importance of different features of our predictive model, those top features are not the specialty group as we expected. Instead, the top 4 features here are different medicines, especially the top 2. They both have more than 50% of importance to this prediction. Number 1, hydroxyzine is a medicine used to treat anxiety, vomiting, and allergies. And number 2, oxybutyn is used to treat certain bladder situation and urine problems. It tells us that physicians tend to prescribe those medicine likely to prescribe opioids as well. And interestingly, the number 9 features here, optometry. So I think we need to be stricter on who can prescribe opioids. Now I turn to Jian. Thank you.
I have to admit that with so many experts from different fields and different species this morning, I learned so much that I haven't been exposed to in the past several years. So, we learn much more about the severity of opioids problems, and fortunately, more and more agencies are open to advanced treatment and including medication-assisted treatment. My research is heavily focused on the evaluating substance abuse treatment, the effectiveness of it, and the implementation of it. So in my research heavily focused on using a large amount of data from different treatment modalities and looking at the effectiveness of treatment, and generally speaking, all treatment models work, regardless is a residential outpatient, intensive outpatient, or in prison therapeutic communities. All of those work as long as clients are having high levels of intrinsic motivation, fewer distorted thinking patterns, higher levels of self-esteem and self-efficacy, and better therapeutic rapport, and of course a other list of factors. We know in the past several decades, research in substance abuse treatment knows so much about what kind of pre-treatment characteristics predict better treatment outcome. We are more and more paying more and more attention on treatment process, to see what exactly happened during treatment that leads to people maximum treatment resources. And so the next research I'm going to present, looking at what make patients avoid treatment. And these clients specifically are opioid offenders who are on probation and parole, and referred to medication-assisted treatment for opioid use. We use ecological momentary assessment, very innovative technology that designed to address the issue of ecological validity. In the past, we have been criticized a lot on the ecological validity of our research. We heavily focus on retrospective data. People ask, maybe people, they have a respective recall bias and something like that. So we use ecological momentary assessment to ask them to perform data assessment during the beginning of the treatment, and we focus on treatment adherence, to which degree they adhere to prescribed medications. The medication here is extended release naltrexone. And we find out that clients with low level of drug cravings and high level of family coherence and discuss interest with family members, and so weak affiliation with peer criminology, they tend to have more likely to adhere to prescribed medication. So those kind of information are very useful to cater for in order to better design medication-assisted treatment for offenders specifically. But those research heavily focus on data, large amount of data, quantitative methodologies. But still, there's something that it's very difficult to find. And in the quantitative data, we know that the information is there, but somehow the statistical model does not reveal significant results. So what we do is actually we wanted to find a technology or find a methodology, review the nuanced understanding of the black box of treatment process. To be more specific, how and why treatment work from a client's perspective. So what we did is we used a qualitative research methodology, and this time we went into a inpatient residential treatment, and we collected 60 one-on-one interviews, and we did a very rigorous qualitative data analysis, and we reviewed several factors that impact treatment engagement, which is defined as to which degree people participate in and cognitively engage in treatment. And those factors include both individual and organizational level factors, either facilitate or hinder treatment engagement. We think they are very informative in terms of inform the clinicians and program decision makers, and in terms of what we should do in order to enhance treatment engagement. Well, the next project we're going to present is still ongoing, and we still use the same 60 interviews, and we wanted to know, well, in each client, and what exactly made them to make positive therapeutic changes. What is the underlying mechanism leading to those positive changes, and in terms of recognize the problem of drug using and have the need for continuous treatment and have the desire to stop using drugs. And we reviewed 3 clusters. The first cluster is is bigger, and 3 clusters of factors that constitute the psychological mechanism that people didn't explain the reason that people wanted to make therapeutic changes. And in the future, we will still continue to looking at treatment, substance abuse treatment, the effectiveness of it, and to be more, also wanted to know how can we implement the evidence-based treatment in order to maximize the treatment benefits. Now I'm turning to Jada, and
Okay, so going along with what Mr. LaBar said, I was kind of inspired by the interdisciplinary approach of this, and I think it's great that we have multiple people in here from multiple walks of life talking about the same thing. We're all here for the same goal. And when I was asked to speak, I thought a lot about those in the Codathon, specifically to let you guys and gals know what work has been done, what missing links there may be, and how we can all work together to move forward. You'll see here just a couple opioid headlines that are very recent. So it's obviously we're here for a reason. This is in the media. People know that this exists. But what are we doing, and what are the missing links? Dr. Clark obviously talked a little bit about the prescription versus the non-prescription. But do our residents of Louisiana know what's happening in our community? And I tell this story a lot. I think about my grandmother. Does she know the risk she may have just in her medicine cabinet? Does she know what that risk may pose to my nephew who may visit her? Do my students walking on campus know? Do they understand where their part comes into this, but also being educated and helping themselves as both a patient and someone who may be prescribed opiates? What you'll note here is that 1 in 4 people receiving prescription opioids long-term in primary care struggle with addiction. 1 in 4. That's a significant number. And then for those of you reading this slide, focus on this 40 times. So those who are addicted to opioid painkillers are 40 times more likely to be addicted to heroin. And we all know the risk of that, as what Dr. Beau Clark said earlier. That is very significant. I know that that number in and of itself was kind of jarring. So another little story I like to tell, I actually live in Orleans Parish. I'm a native of Lafayette. This is my alma mater. This is important to me. But that being said, Orleans Parish, we get a bad rap, obviously. But I was speaking with someone in a healthcare profession in St. Tammany Parish recently, and she's an educated woman. She said to me, hey, that's not our problem. That happens in Orleans. You guys have that problem. You can see on here, that is a very inaccurate statement. St. Tammany is almost double Orleans. So that struggle in and of itself is overcoming that barrier. Do the people walking in our streets know what's going on in their own communities? If a woman in a healthcare profession in St. Tammany Parish is telling me that there's no problem there, and then the funny part is she says, well, we should probably tell somebody about that. And I thought, well, yeah, of course, right? And I put this up there just as an anecdote. I mean, these are straight numbers. These exist. I didn't make these up. I got these from the LPH website. This is the kind of information that needs to be out there. And it is getting out there, but at what level, at what volume? Going along with that, one thing I'd love to talk about is that perception. When we're talking about a doctor prescribing something to a person, that's a different perception. As a doctor prescribing something, that's medical advice, right? So my doctor gives me a prescription, I'm going to take it. I'm going to get better. I'm going to feel healthy. But we're not keeping in mind what those risks are. Luckily, things have been changed and we're moving in that direction, but I think a lot of that comes from that. And again, going back to my grandmother, I love her, she's great. But she does not understand at times, and we've had to educate her on these types of things. And that's one of those things that as a person being educated in my own field and knowing these things exist, I can help her and other people make better choices. And I just put this slide in there. We've probably been through this about 6 times. You'll probably see it about 6 more today. So, and then talking about medication-assisted treatment and naloxone. And those are some questions. These are great. They're saving lives. They do exist for a reason, but how are they working? And this may be something that the Codathon guys and gals can get in for us. Are other countries or other states doing something and they're being more successful? And how can we administer that here in Louisiana to save some lives here? And these are some questions to consider that both Drs. Chen and Jian and I came up with about reducing the number of deaths. But what I like the last one, how can we come together as a community and work together? And obviously it starts here. So the last thing I'll leave you with, today 111 Americans will die from an opioid overdose. Thank you.
Thank you very much. Ramesh, I hope we can make these slides available to everyone today. The data presented in these last 3 presentations were invaluable, and I love what you were able to do with the state-based data to give people a much better idea and a much more granular look at how opioids are impacting the communities around us. Now I have the pleasure to introduce Dr. Vindell Washington. He is an old friend of mine. I've known him for a while, and this is interesting. So, well, first of all, he was in Washington, D.C. not too long ago. Today he serves as the Chief Medical Officer for the Blue Cross Blue Shield plan of Louisiana. He brings the state's largest health insurer extensive experience in leading clinical teams and in health IT, and he's most recently the National Coordinator for Health IT. And this is at HHS in Washington, D.C. Before that, he was at OLOL, Our Lady of the Lake, and he was served as president of the medical group for 7 years. And the woman who preceded him at the Office of National Coordinator is Karen DeSalvo from New Orleans. So in the last 5 years or so, we've had, including myself, and I'll include myself as a Louisianian, especially during crawfish season. So if you think about in the last 3 years, the last 5 years, 3 of the nation's top technology officials for the U.S. government were from Louisiana. So take that, Massachusetts. So it's great to have you here, and it's great to have you back in Louisiana. So please take it away.
Thanks, Bruce. Pleasure to share the time here with you, and it was a great experience that we had working over the years together. So, as Brice had mentioned, I'm privileged to serve as the Chief Medical Officer at Blue Cross Blue Shield of Louisiana. And it's really been humbling this morning to hear the great thoughts and to associate with the great leadership that's been here. I have just a couple things I want to share with you. One point I want to make is just how important we think this issue is at Blue Cross and Blue Shield of Louisiana. So we're privileged to have one of our board members, Jerry Gregg, in the audience, and from our board to our CEO, it's something that we focus on with some high degree of intensity at Blue Cross Blue Shield because we think it's such an important part of what we can do and can work with to sort of move the community forward in this space. We have as our mission to improve the health and lives of Louisianians, and we take that very seriously, and that is another one of the reasons that this has risen to this level in the company and that we focus so intently on it. One of the actual activities that we take sort of was underscored by some of the work that was described with Dr. Chen and Dr. Yang in this space, because we really think that one of the efforts we can move forward here is to tie data and analytics, particularly predictive analytics, to actions. And we've done a lot of work and with our own data across the 1.5 million residents of the state that we insure to try to figure out both who's at risk and what we can do to help those folks, and number two, to prove that the actions and interventions that we undertake really are effective when we sort of move those to the field. So really I have one main job, and I'll move to that right now. And so Dr. Gee had mentioned earlier that with our culture, a lot of what we do is around music. And so my job now is to play hype man for the team members that are to follow me. I just wish I had a cape that I could toss on them, sort of in the style of James Brown as we move to that point at the top. But the main thing I want to underscore is that we've taken an approach, and these two folks have really been superstars in the work that we've done. Brice Mohundro from the pharmacy team, as we believe that these partnerships, particularly with our providers around focusing on what can be done and using the data effectively, is a critical piece. And then Brian from our health and analytics team, because we think that using that data is really the highest and best use. And we hope that sharing some of the work we have done and that we plan to do moving forward in this space will be helpful in moving some of this dialogue forward.
We get a little assistance with in the deck. So this reminds me of another joke. Why did God create economists? To make weather forecasters seem a lot more accurate. I think I'm really running out of jokes. Hopefully we'll have the deck up in a second. You really don't want to hear any more of my jokes, I'm sure.
I actually could start.
Yeah,
Do you want to say something
just
else?
get started? That would be great.
Oh, no. So I can talk about just some stuff that's not in the slide that I think is exciting, and it has been mentioned by all the other speakers. So we've talked about having all these different players and communication, and so at Blue Cross we really feel like that's important. And that's kind of the backbone of our strategy, is not just what we can do by ourselves, but what we can do working with our providers in our community. I think one of the great things that I love about working about Blue Cross is that we do have a very strong community involvement around the state. So there are several members of our team that are involved in both local and national opioid task forces. And we all know how important it is to communicate and to all be involved with the community to help this issue. What's up? Just saying until we get closer.
Okay, yeah, so it's the hype man's job to keep the things moving until the slide deck is going. So I want to share one other quick idea that the team has worked on that sort of fits into it, and it might actually be relevant to some of the coding work that people will discuss later on in the day. So one of the things we've done on the predictive analytics side is to essentially use new data sources to add to the model of prediction. And so one of the problems that we found when we first started on this effort is that using claims data, and particularly claims data that had matured, was just too long of a time lag to provide actionable information. So it's pretty clear that one of the things that we've been able to do is changing the sources. So I'll just share a couple of the new sources. One of the things that's been particularly interesting to me is that you can use data from your call center. So we use a voice-to-text translation to take the actual words that are exchanged between our front desk folks and members to do correlations between the kinds of things that are discussed and the actual predictions that come from that. And so voice to text and the cloud computing speed that was required for that has become much less pricey. And so, and one of the slides I think we'll talk about later on is the way we've been able to use some of those sources. And so I think I would encourage you, as you think about the kinds of things that you can use, whether it's the voice to text, whether it's things like credit scores, whether it's things like Geography +4, there are a lot of new sources that if you have enough computing power that you can use in some of these predictions. And the point of it all is that some of these treatments are particularly expensive. Some of those are new and on the horizon, and we can't really as a nation afford to use interventions like peanut butter, spread them all around and hope they work. Some of the idea about the predictive analytics is to say, for these newer ideas, number one, can we prove that they work with some propensity sort of matching and analysis? And number two, once we found that they work, can we target them to the right folks? So, Brice.
Okay. I'm Brice Mohundro. I am a clinical pharmacist at Blue Cross Blue Shield of Louisiana. I have been there about 5 years. In my prior life, I was a professor at ULM College of Pharmacy, where I worked in a family medicine clinic for half of my time. So I got to see this from the clinic provider side, and now I'm working with it on the health insurer side. So this is just a couple of different statistics that we haven't thought about or we haven't talked about today yet. So prescription drugs are the second most abused drugs after marijuana. Almost 12% of young adults ages 18 to 25 use prescription pain relievers for the first time in the past 12 months for a non-medical reason. Youth and young adults were more likely to misuse prescriptions than those over the ages of 26, and youth and young adults were defined as between the ages of 12 and 25. And then the average age to start misusing prescription drugs, so using these prescription opioids for non-medical reasons, is from the ages of around 21 to 22. And 1 out of 4 college students have misused prescription medications in their lifetime, according to a self-reported 2015 study. And then on average day, the past year, over 5,000 adolescents, so that's that 12 to 18 range, misused prescription relievers for the first time. So we've been talking about all these national and state statistics, but I wanted to talk about some of the statistics more relevant to the younger population. So what I'm going to do is Dr. Washington talked about how important this is to Blue Cross. I'm going to spend the next few minutes just talking about what we have implemented so far as the first step in a long process and strategy that we will continue to improve on throughout the years. So what we did was we decided that the first thing that we were going to do was try to tackle this from a pharmacy utilization management perspective, meaning that we were going to try to limit the number of opioids, the quantity limits, and how many day supply, how long of a day supply that patients could get. So we've had some different discussions or different comments about 3 day supply versus a 70-day supply versus a 30-day supply. So what we decided to do was, we have 2 different kind of strategies within the pharmacy benefit. So the first one was what we consider quantity limits or safety edits. So these are really not have anything to do with the amount of opioid that's in a prescription. It has to do with that secondary analgesic. So that's a different medication that works on pain that's not the opioid. So like Tylenol, ibuprofen. So we've talked about a couple of those before. So our first one limits the amount of Tylenol to less than 3 grams per day, and that's because studies have shown that going over that limit can increase harm to the liver. And then also limiting our ibuprofen and aspirin containing drugs also to those limits that have been considered safe in studies. The other thing that we did is in line with the legislation that was passed last year and that went into effect in August. We talked about the 7-day supply for acute prescriptions. Dr. Clark mentioned that. So what we did was any drug that is written for greater than a 7-day supply will require a prior authorization. So for those of you that are not familiar with the prior authorization process, you go to the doctor, they write you a prescription, you go to the pharmacy, and then the pharmacy says, oh, you can't get this. We got to call your insurance company because they want us to go through a couple of steps first to make sure you should get this drug. So what the physicians will have to do is call in and get an authorization for anything greater than a 7-day supply. So that's kind of how our strategy started, and then the legislation passed which supported our strategy, which we were excited about. But then we kind of started looking at our data and thinking about different things, and we noticed that we had a lot of members that were getting opioids filled for like a 3-day supply and a 4-day supply and a 7-day supply. So they would have never hit that first prior authorization criteria. So we added a second step to it, where if a member got greater than a 21-day supply within a 60-day time frame, that they also would have to go through that prior authorization process. And then that's for our short-acting opioids. So that's like your Loratab, your Vicodin, anything that is usually for an acute indication. So you broke your leg and you're getting something 1 to 2 tablets every 4 to 6 hours for pain. Then we also have our long-acting opioids, which are your OxyContin that's been mentioned, fentanyl, patches, anything these are for patients that are experiencing pain around the clock long-term. They shouldn't be started out on these drugs. They should have tried a short-acting first. So the prior authorization for this is more just for appropriate use and not an actual day supply. So did they try a short-acting opioid before trying this? Did they try these other alternative treatments before going to the long-acting drugs? One thing that we did do was it's a kind of a fine balance with opioids and pain. We want to help curb the opioid epidemic, but we also don't want to harm those that actually need to be treated. So one of the steps that we took for this is that we are excluding any member that has cancer from these prior authorization requirements. They still will have to meet those step therapy requirements because those are from more of a safety issue from the non-opioid component. But for cancer patients or anybody receiving an opioid for end-of-life care will not be subject to these prior authorization criteria. The second thing that we did was, so we implemented this January 1st of this year, and what we did was we didn't want to both overwhelm our physicians with all these prior authorization requests on January 1st, and then we also didn't want to harm our members that have been on these treatments for a while and need these treatments. So we grandfathered anybody that was on an opioid 130 days before January 1st. So basically from August 24th through the end of the year, they were still able to get their drugs without going through this prior authorization process. One of the things that they have to call in for the prior authorization process. So I know our Lafayette General David mentioned a couple of different things that they're doing, and so it kind of goes hand in hand with what our prior authorization criteria says. So basically, the physician has to say that I documented in my medical record that I considered alternative therapies to an opioid. I discussed the risks and benefits of opioids with my patient, and then also I did a risk assessment. So I really liked the Cerner piece that automatically does the risk assessment for you. And then you also have to have a pain contract. And so once those steps have been completed, then they can get a supply that's greater than 7 days. So like I said before, we really felt like collaboration with the community, collaboration with our providers was a very important piece to the strategy. So we started talking to our providers and educating them about CDC guidelines, actually several years ago when the new guidelines came out. As part of our Quality Blue Collaborative, we started that education early, and then this past October we started educating about this new strategy in face-to-face meetings with our providers, emails, and letters. And then we also created a toolkit for our providers that's found on our prior authorization pharmacy page of our provider website that has information about the CDC guidelines. It has sample pain contracts, sample risk assessment tool, on there for our providers just to help with that education piece. And then also for our Blue Cross members, one thing that we did was that we sent letters out to our members letting them know about these changes that were coming to our opioid coverage. And then also our population health nurses who are on a daily basis talking to our members, they have incorporated some new changes into their workflow to discuss, let's say a member is scheduled for surgery. So they're going to have a conversation now with them. Hey, you're going to have surgery. We kind of talked about this a little bit earlier. You're going to have pain. So kind of setting realistic expectations, and then also letting them know that they don't have to take the opioid. There's alternatives out there, and sharing with them what the risks and benefits are of those drugs. So when we started looking into this, we wanted to see what our population looks like and what the Blue Cross members' opioid usage looks like. So what we found, we looked at 2016 data because we started looking at this last year, and that was the most current year of a whole year's worth of data that we had. And what we saw that were, of all the prescription claims, so we have about 650,000 members with a pharmacy benefit through us. Of those members, about 3.7% of all prescription claims were for an opioid. About 20% of our members had at least one claim for an opioid prescription, and 94% of our opioid prescriptions were for those short-acting Vicodin, Lortab, hydrocodone, with Tylenol type products. And then we have the details down here. The other thing that we noticed was that the majority of our members were receiving a 7-day supply or less of the short-acting opioids. Then you'll see it kind of decreases a little bit when you're looking at between 7 and 10 days, between 10 and 15, 15 and 20, and then jumps back up for prescriptions that were written for 30-day supply or greater.
How's everybody doing? Brian Badinger, I'm the Director of Enterprise Data Management. Couldn't leave today without saying data warehouse or maybe Hadoop or Spark or something else, so I figured I'd throw it in there. For the past couple of years, we've had a big initiative, see the clock ticking down on me, it's not gonna make it, on the enterprise data warehouse. We have really consolidation of internal and external data sources. You can imagine the amount of data that we have. Before, it was kind of distributed throughout the organization. We've done a great job of pulling that together, and it really changes how we can deliver it internally to kind of change the services for our members and providers. You can kind of see a lot of the core parts. I mean, some of it's internal and some of it's external, like consumer demographics data. We have a big initiative. We're making headway on the clinical data exchange. Some of that data we're getting every 6 hours now. Some of the data in the warehouse refreshes nightly. So it's really real-time, near real-time data as we get. Dr. Washington mentioned some of the work. We're in the early stages around some of the Spark and Hadoop big data platforms for our predictive modeling, but also it has other uses, you know, kind of staging off other data, staging some incoming clinical data where your unstructured data, you know, such as physician notes and some of the EMR type data. But around the, you know, the Hadoop and data science work, we have a number of predictive models, kind of one member risk of hospitalization. We noticed we ran it internally, and then we moved it to the big data platform, and just being able to expand on the number of data elements that we're able to use, going to 20 or 40,000, really increases the accuracy of that. And he also mentioned kind of some of the text mining around the customer calls, and being able to look at maybe someone multiple chronic conditions, seeing a pattern that they're the top callers all the time. Maybe we could reach out to them. Maybe they're in crisis. Maybe we can call them before they call us. Those type of scenarios. So these are some efforts to kind of get us and service our internal and external partners. Now I have some visualizations. I'll show some to kind of give maybe the coders some ideas of as they explore what they're putting together today. I have some more geared towards opioid. But these are some that I could show. Some of it obviously is really sensitive data, so I'll show some that I could share with you. We have kind of around our data excellence is our program and project team that we have around the EDW. We have a dedicated team that kind of develops these business intelligence dashboards and visualizations to enable our providers and internal departments as well. This is one where you can see, based on the EDW data, pharmacy data, we can pinpoint the drug name, you know, depending on who we're looking at, the number of kind of refills that they have on that particular drug that was dispensed, how many unique, distinct providers or prescribers, should I say, that they visited, and they also kind of, the red indicates like a Schedule 2, Schedule 3 type drug. So when you're looking at this, you can quickly identify, maybe to hone into this data point quicker than honing through, you know, Excel spreadsheets or a massive amount of data in a database. So it's a kind of a quick identifier. As you see, we're in 18, so the data is up to date, which is very helpful when you're starting to do some of the analytic work. This is another one I thought was pretty neat, working with a large health care system in Shreveport. being able to, and so we use reference data in a number of areas like NDC, which is National Drug Codes. We have other reference codes, but we also use kind of drive time data. So we'll be able to look at a particular provider area and then pinpoint from the members' locations how far will it take them to drive to that particular hospital or provider's area. Do we need to expand that provider network to service our members better? So we're able to kind of do this type of analysis, which is really changing the way we're looking at kind of developing our networks as well. We provide kind of internal look at some of the clinical conditions, chronic conditions. This is kind of a look over 2 different years that an internal team was looking at. Also, we have the later years as well, but I thought this was an interesting view to be able to kind of look from year to year as the chronic conditions grow and change over the course of time, kind of pinpointing some of those. Again, some of the geolocations capability that we're able to do. We're able to put this together so the coders, you could really look at maybe pinpointing geolocations and saying, keep pressing the wrong button. Apologies. You could really look at maybe kind of the scripts field in a certain location. Maybe you got a hotbed of members or users in that area. So you can start plotting some of this information. This one is just strictly on group location. Some of our groups that we have and our members' locations throughout this particular area. But you can have some ideas as you work this afternoon. So we put this together Wednesday just because I knew I was coming here and just kind of leveraging some of the data. I know I wasn't going to make that. Being able to look over the course of the time and it kind of goes against some of the other information that we saw from the number of people with scripts and the amount of scripts. And I did, we have some we have drug classes, and this one was kind of filtered on that drug class at the bottom. But it kind of shows you the peak in 14 and 15, and then tapering off here as we get into 17 and hopefully continue to see that trend. Again, this was another look, and the coders just trying to give you some ideas. We kind of broke this down by age group, kind of more demographic breakdown. Being able to look at the number of scripts by age band. And the bottom is the number of people in those age bands, and it kind of correlates. And it sees as definitely when you get over the 26 age band, it definitely increases. So I thought that was also an interesting look at it. And a lot of functionality wasn't maybe fancy as some of the drive times or geos, but we also are able to plot kind of the per script for the people who have it, how many scripts are those people actually getting for the opioids. So we kind of plotted that on the map. This is more real-time data, right? It refreshes nightly as we get claims in. And so you can see the hotbeds that are kind of a heat map and shows you different corridors. So when you're looking at your data, perhaps some of the other maps that we saw, maybe those people don't have transportation to get to the hospital. So maybe that's, they're falling into certain patterns and behaviors. So those are a couple things that I thought were interesting. So any questions from what you saw? I think that was all I had.
We just wanted to show you one more slide on the impact of what we're doing. So we are going to measure the number of opioid, the total quantity available to the community. So like I said, we're trying to decrease that quantity that's left over that could potentially be used in an inappropriate way. So this is just showing all the way back to 2014. So like Brian said, our opioid usage spiked in 14 and then has steadily come down since then. But you can see over here on the very right-hand side, right there was December of 17, was about right there, and then this is where we are at the end of February. So even with just 2 months of our new strategy, it's made quite an impact, significant impact already. Thank you.
Thank you very much. We're going to tee up the last slide presentation. And so what I'm going to say about the last couple of slide presentations, and trust me, this is a compliment, they were boring eye charts filled with data, and they told so much of a story. So it's an enormous compliment. What we're doing is, in your plan, Blue Cross Blue Shield, the depth, and by the way, you have a long history of using data to do a variety of types of analyses, whether it's looking at variations of spend or consumption, pricing. It's all very helpful. And so the other work that was done here by Drs. Chen and Yang were really illuminating to look at what's happening around the state in various parishes, and it really changes what our perception is of what we think we know everything. That's, oh, it's an Orleans problem, or it's not a problem elsewhere. I just saw the variation in the average number of scripts that you showed. Along the northern border, it's about half of what it is on the southern border. I don't know, people have a higher tolerance for pain there? Is it a different culture? But those are things really to explore that are really important. Okay, so I'm going to present a perspective from Washington, D.C., and I'm going to also kind of tell the story of what we did with our opioid event in December and how we used it as a bit of a move to change culture and focus on data, and that has rippling positive impacts. Let me just tell you a little bit about our lovely building. This is the HHS headquarters, the Humphrey Building, the second ugliest building in Washington, D.C. It's a beautiful rendition of brutalist architecture. Interestingly, the most ugly building in D.C. is Housing and Urban Development. How appropriate. Would you agree? Yeah. This is only slightly better, which isn't saying much, but it houses a lot of very, very important American institutions. And if you think about it, about 80,000 employees and then hundreds of contractors behind that. And here are the four premier agencies, and then I'm sure there's going to be people hitting me on Twitter. No, our agency is just as important. But think about this, in any other country in the world, CMS that runs Medicare, Medicaid, in any other country in the world, that would be the largest governmental department or agency on its own, and it's one of many. The FDA, so critical in our everyday lives in the United States. FDA approves 1 out of every $4 that we spend on stuff, not just drugs or devices, but what we eat and how we treat fields. It's an incredibly important agency that operates also under the umbrella of HHS. NIH, the National Institutes of Health, is the world's premier biomedical research institution with about 34, now it's going to be higher, $37 billion in spend, and I'm sure a lot of that money has made its way and had a very positive impact here at ULL. And of course, CDC, which is one of my favorite agencies, not only does it do an amazing job to protect the public health of us here in the United States, but very easily, if you think about it, CDC has saved the world several times in the last 10 years when international institutions have not delivered as well as they could have. Think of Zika and Ebola. We have a whole group of people at CDC that come to work every day in Atlanta, but they keep a duffel bag packed by the front door. And the day that they're called up, they run home, get their stuff, and they're on a plane to go to another country and really go in and essentially save hundreds of thousands, millions of people and populations across the globe. And it's really incredible. And it's an incredible honor to be able to work in this department as well. Getting to the opioid crisis, this is an area that it's really not about politics, it's about figuring out what to do to solve a problem and save people's lives. It's incredibly important right from the very top. The president has talked about this over and over again. We talk about ways to address it. We think about rates of prescribing, and we talk about ways of addressing that there. We talk about what we've done. And I had a couple of discussions this morning by the lady who's the head of the behavioral health agency here. Are you still here today? Okay, great to see you. So money is flowing from HHS to government agencies in state governments all across the country. And then from there, it makes its way to usually grantees, probably organizations that you've worked with over the last maybe 15, 20, 30 years to really have an impact in our communities. And if you think about this, I'm going to try to continue to draw these things together. In DC, we put out money that goes to states in the form of grants that then go to organizations in the form of grants to then have the most appropriate impact in the community in ways that the community is designing. So we have very bright, insightful people at the community level that really know the contours and landscape of their communities, know their populations, but they could have even more insights and information from the data that we continue to produce, whether it's produced at the federal level or here at the state level. But the analyses and insights that the coders will be able to produce, the data that you saw produced today in the form of insights, will help everyone that's taking dollars and trying to save lives with it. It will make their job more potent and more effective. So everything that we're doing in this area, all the boring presentations that we're producing, they really, really help directly save lives. Everyone is trying to do their role. Everybody can help each other, getting back to the interdisciplinary approach that Will talked about earlier. Very important. So SAMHSA is our substance abuse and mental health agency, pushed down only almost $500 million last year. Some secretaries of health around the state, my former colleagues, told me that it was sometimes hard to spend. It was so much more money than they're used to getting that it was difficult to spend. So I would say for those that are interested in working with your own Bureau of Behavioral Health, start thinking about new and innovative ways that you can partner up in Baton Rouge to help people in your community. In HRSA, that does rural health, I can tell you right now, in the next year, there's going to be a lot more opportunities in FQHCs to do MAT, medically assisted therapies. This is something that we're going to need help. We don't possess the capacity today, yet we know that there are people out across our state that need help there. So this is going to be for a rural state like Louisiana, it's going to be a great help by offering financial support to be able to run these programs. CMS, Dr. Gee earlier today talked about some of the pioneering work that the state is doing here with CMS. I think it's serving both as a bellwether but also as a best practice that other states are watching, figuring out the results that we'll get here to be able to replicate across the country. And the Surgeon General, who has a very personal message with a brother that is struggling with addiction, is putting out some of the most common sense and heartfelt guidelines to really help organizations, people, families, professionals all across the country make better policies and better decisions. So what's next? This is pretty big because Senator Cassidy this morning talked about new dollars that are going in the most recent budget bill, on top of the monies that we had already allocated, some from the 21st Century Cures Act and some from existing legislation before. These are very large amounts of money, and they're not being spent in DC, they're being sent mainly to states to then get out to communities. And so for anyone that's working with the state today, be thinking about how you might do things bigger or more effectively or more collaboratively, because there will be an opportunity. For those that are not working with your state agency today, think about ways that you could partner up. I know that there's big open minds in Baton Rouge that are interested to partner for the most collaborative, most effective way at carrying out treatments or approaches to dealing with the opioid epidemic. All right, so we put on a codathon. This is a picture of myself and Dr. Mona Siddiqui, who's here. She's the Chief Data Officer. I have the pleasure of working with her. And she put on this, it's a great picture of her, kind of questionable of me. So we put on a codathon in December. And it was in response to the Secretary's ask to shine a light on what's happening in the opioid epidemic. And no one should be thinking that they don't have a responsibility at HHS. And we, the data people, thought that we have a way to use data to help save lives, to make that direct connection, to do what y'all are doing here today. And I'll tell you, the process of putting together 71 data sets from across HHS that have never been grouped together before, from 5 different federal agencies, including the Department of Transportation, which collects 911 data, which really tells a lot about what's happening in communities. It was eye-opening for people that run their data sets in their silo, we call it, but in many times it's a lockbox. It gets used one time for one purpose only and doesn't get used over and over again to solve other problems. Again, it was a cultural change. People had to think differently about not their data, but the people's data. Not data that only has one purpose, but data that has many purposes. Not data that's just for reporting on one phenomena, but data that could be used to save lives. And incrementally, we're making changes in the way people think about data ownership and data usage, and it's really great. So again, we were able to connect a lot of data that hadn't been connected before and serve it up all in one place. We had coders from all across the country, from large technology companies like Google, Facebook, Amazon, Microsoft was there, SAP, Palantir, Socrata was our platform, and they're here today. We also had people that came from the university scene, the best universities in the world, like Stanford, MIT, Harvard, Yale, and ULL, all sitting next to each other. It was really cool to see. And the solutions that we got were really first rate. So we did our challenge prompt in 3 sections around treatment, usage, and prevention. And over the 51 teams that were battling out using this big data set to come up with new solutions and analyses, they really focused in these 3 areas that were helpful for them to coalesce their thinking around and direct their solution towards. So what we got was really interesting, because for us at HHS, people that are running these programs, that own the data, that are giving out hundreds of millions of dollars, they got to see a different perspective. College kids that really don't know about government bureaucracy and grant funding and how state agencies work, they looked at something like, for instance, take-back programs on the first one. So an app was created that was just like my Starbucks app. When I want to go get a coffee, I look for where the nearest store is. They were able to do the same thing for take-back sites where you can bring unused opioids back. And what we found by displaying this was in areas that we had little problem and great problem, we had vast geographies with no place to take opioids back. Even when you lay on top of that areas that had high opioid prescriptions. It was really, for us, it was intuitive to think about, but we had not done it before, and then it's a great way for us to address problems and for people to use it to go and get opioids out of their medicine cabinets and out of their house where it could be potentially abused by other people. Real-time tracking of overdoses for first responders. So we heard Dr. Clark this morning, or this afternoon, this morning, talk about fentanyl. So what happens is in the supply chain, when a bad or a very potent batch of fentanyl hits the streets, it's not like an overdose happens one day and 2 weeks it's another. Oftentimes they start to pop in the middle of the night. And so by giving first responders real-time access to where these overdoses are occurring, we're able to mobilize resources, cut down on the time it takes to get people to intervene and save more lives. Again, these are companies and students, people collaborating, drinking a lot of coffee through the night, eating pizza through the night, coming up with new ways of looking at our data in a fresh way, a fresh approach that will eventually help to save lives. And the last one was around visual representation. We've talked from Blue Cross Blue Shield perspective about prescribing. I'll tell you what was very effective is when a physician sees how much they prescribe relative to their peers in their town, in their zip code, in their county or parish, and across the state. It really makes some question what it is they're doing in isolation and maybe look to get some help about what the most modern ways, the best practices are to approach prescribing opioids. It was very effective to see that, and I could tell it made some people in the audience a little bit uneasy. So we have a new secretary at HHS. I can't tell you how excited I am to have Alex Azar as secretary now. We worked together in the Bush administration where he was the deputy secretary. He went on to be the president of Eli Lilly North America, and he brings a business acumen in running the department. And after his first 90 days, he put out his 4 transformation priorities, and he'll execute against each of these priorities in a methodical and disciplined way. And it's great to work in an organization that is working that way. Number 1 is combating the opioid crisis. We've already put together a team. Let's see if I have. This is the way, our strategy to go about it. Basically, it recognizes these 5 domains, and it says that we're not doing any of them as well as we need to. So it's about getting better in each of these areas. We put together this Francis Collins, the head of NIH in the center. By the way, watch his name. You'll see him win a Nobel Prize, I think, in the next 5 years for decoding the human genome. You see Scott Gottlieb, who's the head of the FDA. All of us got together to wrap our minds around what we could be doing better to address the opioid crisis. This was just last week. Actually, it's earlier this week, now that I think about it, on Monday. And it's the way that we begin to start to address the way that HHS will look at the opioid crisis, how we'll put all of our best assets and the brightest minds against it, and then work with everyone we can around the country to try to do our best job in solving the crisis. From our office, we think we're in a unique, at least an unusual position, because we will work across the entire department. We work every day with CDC, NIH, FDA, SAMHSA, HRSA, AHRQ, the whole way across. And we do it by looking for both data and solutions that can be used across the department. We're not stovepiped, we're not siloed. Our value proposition is to lever data and ideas across each of these agencies to make as big of an impact as possible.